Hello, welcome to Miyara's webinar. Today, we have Dr. Vikram Talaulikar talking to us about things you wish you knew about menopause and didn't know whom to ask. It is going to be an interesting talk, and welcome, Dr. Talaulikar.
Thank you, Gayatri.
Yeah.
Thank you, Chandana.
Just before we go ahead, I want to tell you a little about Miyara, who we are presenting this today. Miyara is your guide to midlife health. We are a science and evidence-backed health and wellness platform to support women in menopause transition and for healthy aging. We primarily are a wellness platform. We focus on the nutrition, fitness, habits like sleep, mindset, and mental health, of course. We also have at-home diagnostics on our platform to offer you. So we have started last year, and we are now reach about 6,000 people. We have a Miyara community on WhatsApp and on Facebook. So if you'd like to join any of these, feel free to join. Our website is there, and you can look at our website. What is it that we actually provide? We have information. Information and awareness is primarily what we give. It is through our website, blogs, and social media. We have personalized health and wellness programs for women. And this is one of our main focus because as Dr. Talaulikar will talk today, and as we also, some of you might have heard during this live stage, lifestyle changes becomes important apart from the whole medical intervention that you can have. And apart from that, we do have certain at-home diagnostics that we provide, that we are partnered with, and we do corporate sensitization, awareness, and wellness training too. So, and then briefly, who are we? I am Dr. Gayatri Muthukrishnan. I've done my PhD in bioengineering in US, and I'm currently living in Switzerland. And my co-founder is Dr. Sanjana Rao. She also has got her PhD in biochemistry, and we are here because we really believe health communication, communicating health to everybody is important, and our focus is women's health and midlife. So that's where we are now. And finally, I would like to introduce our speaker today. Dr. Vikram is an OBGYN by training. He has done, he's a reproductive medicine specialist at University of College London Hospitals, NHS Foundation. He's an honorary associate professor in women's health in UCL again, and he's a menopause specialist. What is interesting is PhD, along with being trained as an OBGYN and being a menopause specialist. So he also focuses on research, and he has published many research articles in reproductive medicine and menopause. He also runs a busy menopause and PCOS clinic in UCL and a menopause clinic in Harley Street. And he's also a principal trainer for FSRH menopause SS module and a trainer for BMS principles and a practice of menopause care program. So obviously he has got a lot of experience coming in, both clinically as well as in research, and really looking forward to hearing more from him.
Thank you. Thank you. So as I said, next 20 to 30 minutes, I'll try to be very, very quick and just give you overview of what the current understanding about menopause and the HRT is, and then let's go straight to questions and answers. So who am I? I do clinics at University College London Hospital and Menopause Clinic London for the last 15 years. And I'll be sharing with you some of my experiences in the clinic. I'll start with 3 questions, which is often what gets the talk started. And often, if there is time, I often ask you to give me answers, and we kind of then decide who is right, who is wrong, and you win a prize. But we don't have time for that today. So I'm going to give you the answer straight away on the next slide. So what is the commonest killer of women in England today? And that's going to be most countries in future as well. What most commonly puts women and physicians off HRT? What could be the most effectively the solution to improve a woman at 50 or 60 whose energy levels are low, sense of well-being is low, and rekindle her interest in her partner. Some of the issues that are mostly presenting at midlife. The first one, I often get the common answers such as heart disease or cancer. You'll be surprised to know it's actually dementia. The second one, what commonly puts women off their physicians of HRT? Yes, this is probably more common knowledge. It is the breast cancer, the big C, that often puts women off HRT, and lots of doctors will not prescribe HRT for the fear of blood clots or cancers. We'll look at that shortly. What could most effectively improve a woman's libido? If there's no other cause why that has happened, it's a drop in libido, drop in energy. And again, I'll touch upon this at the end. It is testosterone, which is thought to be a component of HRT now, and it used to be a neglected hormone in the past. Okay, so let's go to the basics. When does menopause happen? What are the symptoms? How do we confirm someone is going through menopause or has gone through menopause? Should everyone have a blood test before considering either hormonal or non-hormonal treatments? 4 questions which are most commonly asked. So to understand that, first of all, we look at the journey towards menopause. Why does menopause happen? If one were to answer scientifically in a single sentence, the menopause happens because the woman's store of eggs is exhausted. So every woman is born with a set number of eggs, millions to start with. And as the woman will grow old, she will keep using the eggs in her egg store. So by the time she gets to the age of late 40s or early 50s, only 1,000 of those million eggs will be remaining in the ovary. And this is when the eggs or the ovarian store has got exhausted. There will be no more hormone coming from the ovary, and the menopause happens. We don't know why there is a set number of eggs in terms of the actual scientific reason behind it. We also don't know why women start with millions of eggs and they get used over time, although the woman will only release 1 egg every month during ovulations throughout her life. But what we know is once the store of eggs gets exhausted, the hormones stop and menopause happens. Now, we have 4 stages that we describe in journey towards menopause. The first one is premenopause. This is when a woman will be having regular periods, menstrual cycles of about 28 to 35 days. She will be ovulating once a month, and no hormonal aberrations or fluctuations are happening. Just the normal cyclical pattern of hormones happens every month. The second stage is, of course, the perimenopause. This is when hormones start fluctuating. So this is the first stage where something is starting to change. The hormones, estrogen, FSH, LH, will keep going up and down quite markedly. And the perimenopause will usually be characterized by either changes in periods. So the menstrual cycles, instead of being 28-day, may become shorter, may become 14, 20 days, or may become longer, 60, 90 days. So periods may come more frequently and then become more spaced out. Besides the periods, of course, some other subtle symptoms may be noticed. For example, changes in mood, changes in some sort of temperature regulation, hot flushes, night sweats may start coming in, energy levels, libido levels might fluctuate. And those might be the only signs of changes before periods start having changes within themselves. So the perimenopause is when some changes are happening, may last between 2 to 5 years for most women, between age of 45 to 50. Now, these are just guidance average ranges. Remember that for some women, perimenopause may happen for 7 or 10 years before actual periods stop. For others, it might be just a year or 6 months of fluctuation and then they'll stop periods quickly. So everyone is different and everyone's menopause journey is very unique. Then happens menopause, periods have stopped. It's always a retrospective diagnosis. Once a woman has stopped periods for 12 months or more, and there's no other cause for it, then that is natural menopause, and it's always retrospective. And finally comes postmenopausal phase. This is 1 year since the last period happened, so the menopause is confirmed until the end of life for the woman. So the entire phase after that, it will be postmenopausal phase, where there are not much of estrogen, progesterone, hormones. And of course, we're going to look at what the implications of that is. Now, important that the postmenopausal phase is getting more attention because almost 1/3 or more of a woman's life now is postmenopausal phase. So there are plenty of years which are productive, and the woman should be looking after her long-term health in this major period of life. The whole bit importance about this particular slide is that many GPs might think that if a woman is still having periods, then she's not menopausal, and so she should not take hormones or she should not take any non-hormonal medication. That's not strictly true. So in perimenopause, your estrogen levels are coming down already, and you may be symptomatic if you're sensitive to hormones. And despite having the fluctuating periods or even regular periods, you can opt for taking hormones because you're symptomatic. So that is the key change in thinking that has happened over the years. This is just a pictorial description of what happens to the estrogen, the key female sex hormone. Pre-menopause, before any changes have started, it's lots of estrogen in the body. During perimenopause, 5 years of ups and downs. Some days and some months will be better. Other months will be lots of symptoms. Finally, in menopause, post-menopause, you can see the estrogen levels are almost close to zero. And that's when you have very strong symptoms if you're sensitive to the lack of estrogen. Age at menopause, median age in the Western countries, developed countries, usually is 51. And usually 50 to 51 is considered as average age of natural menopause. But it, of course, depends on lots of socioeconomic, cultural, and geographical factors. And the ethnicity, the genes are equally important. For example, in Indian women, the average age at menopause is 46. That's 5 years earlier than a Western counterpart. Again, this is significant. The importance about long-term health advice and looking after yourself will be even more important for women who are having earlier menopause. Early menopause is classified as 40 to 45 years of age. So if a woman goes through menopause between those age groups, then it's early. That happens to 1 in 10 women, 10%. And premature menopause is below the age of 40. That happens to 1 in 100 women. Remember that menopause can even happen at 20 or 30 years of age, or even just after puberty. So never say never. For a few women who are unlucky, 1 in 10,000, 1 in 100,000, the menopause may even happen in teens. And so it's really important not to dismiss anyone if there are signs, symptoms suggestive that this could be premature or very early menopause. 70 to 80% of women will experience symptoms, and that does mean good news for the other 20% who may have very minimal or no symptom. Again, this is important to highlight. Not everyone has a very tough time at menopause. There will be women who will be lucky to have minimal symptoms or no symptoms, and that's great. But about 75 to 80% will have some mild to moderate or severe symptoms. And those are the ones that we try to treat or manage when we give different forms of intervention. And out of those 80%, about 1/3 will have very severe symptoms. So lots of hot flushes, lots of night sweat, which make life difficult. Main symptoms. Now, again, there are more than 35 to 40 symptoms of menopause which are described. So I'm not going to go into each individual symptoms because we will run out of time, but I've just summarized the important ones, and menopause can impact right from head to toe, every organ system of the body. So irregular periods, hot flushes, night sweats, which are very common and which can disturb daytime or nighttime quality of life. Disturbed sleep, and then often disturbed sleep makes you fatigued throughout the day. Dry hair, dry eyes, dry skin is typical. You have low energy levels, low libido, joint pains, aches throughout the body. Emotional fluctuations can be the only significant sign. So having low mood, unexplained tearfulness, heightened anxiety, these may be typically the first symptoms. Brain fogging, not remembering what you're doing or what you're trying to say. A lot of women I see in the clinic will say, I've had some hot flashes which don't bother me, but it's the brain fog. I can't just recollect what I'm doing or why I'm in a room or in a meeting. I can't find a word I want. And of course, there could be other causes for it, but menopause can cause similar symptoms. Poor concentration, not able to multitask, vaginal dryness, local symptoms, painful sex, bladder symptoms, leaking or having urgency, all these can be head to toe effects of the menopause. And of course, all women will have a different severity and different set of symptoms. No two women will have the same experience. How do we address symptoms? So let's look at the various ways we try and make life better, improve quality of life. And some of these interventions, of course, will also have benefits for long-term health. So you have lifestyle modification, you have changes at workplace, you have nutritional self-help interventions, you have alternative therapies, non-HRT medications, and finally hormone replacement. Now, some of that at the beginning, we saw what Miyara Women is doing. That's exactly working on lifestyle, changes in workplace, changes in what you do, what you eat, how you look after yourself with exercise, nutrition. I'm not going to dwell a lot on it, again, because of lack of time. It's a topic on its own, and we're probably going to cover that in future. But I'll give you a gist of each one a little bit in terms of clinically how we approach each of these therapies. Now, 3 questions, again, going back to the questions we asked. Do you always need tests to confirm you've had a menopause? Do you need a blood test from a doctor to say you've gone through menopause? The answer is no. Menopause is a clinical diagnosis. If you're 45 and above and you're having symptoms of menopause, you do not need any blood test to either consider HRT or any other form of non-HRT symptom treatment. It can be confirmed just based on your signs, symptoms, and you don't need a blood test. Blood tests may be necessary in few women where you think of an alternative diagnosis. So for example, some symptoms may be of thyroid, some symptoms may be vitamin deficiency, some may be iron deficiency, and some women below the age of 40 who may be having premature menopause symptoms because they are so young, you need a proper diagnosis, confirmed diagnosis on blood. Those are some indications where bloods are useful, but for majority, you don't need to have a blood test. Is testing always mandatory in order to start some form of treatment? Answer is no. You can have HRT without a single blood test. Is testing always required to monitor or change HRT? Sometimes yes, but not always. So sometimes, for example, particular form of hormones may not work for you, or your symptoms may be atypical, or you may not be absorbing hormone from patches or gel and you may need to change it. Those situations, bloods can be useful, but generally testing is not required to change HRT. Hormones fluctuate quite a lot in natural perimenopause, and of course, there'll be zero after menopause. So there's no point in doing bloods because while you're in your perimenopause and getting your symptom, every week the hormones will be going up and down. So you could have a test today that shows low estrogen and a test 2 weeks later which shows high estrogen. That's naturally perimenopause. It's going to happen to you, and it doesn't mean that the bloods are inaccurate, but they're not useful. What is available for non-HRT options? So we talked about lifestyle, making sure you don't have too much caffeine, making sure you don't have excessive alcohol, looking after your nutrition, small portion sizes, not too high calorie or too high sugary foods, exercise, yoga, Pilates, any form of exercise regularly 3 or 5 times a week that you enjoy for 30 minutes. In case of practical, light clothing, several layers, which you can remove some of the layers if you have a hot flush, having access to fans, having access to cool temperature device, try and work around that in terms of your lifestyle. Complementary therapies, we do find that some women like to have acupuncture, homeopathy, hypnotherapy. It does work for some women, but not all. Scientifically, we don't recommend these because the evidence is not very strong that it certainly helps everyone. But because they have very low side effect profile, a lot of women do access these therapies. And in my practice, for example, if someone finds it useful, I say go ahead with it. Psychological therapies, you have relaxation techniques. CBT is very useful for hot flushes, night sweats, and mood. So if you want to access psychological therapies for symptom, then cognitive behavioral therapy is very useful. Mindfulness, of course, is another technique. Herbal products, you have lots of over-the-counter herbal products available, including black cohosh and starflower oil and red clover. Again, medically, we don't recommend these because there are no long-term safety data about these medication. Some women find them useful and do continue to take them. I don't recommend them, but if someone takes them and finds them useful, I just caution about the long-term use and they may continue. What about non-hormonal pharmaceutical medicines we have? So I'm going to talk about HRT in a minute, but before that, just completing the list of medication. You do have non-hormonal medications which can help with symptoms of menopause. If you're getting bothered on a day-to-day basis, not able to work, life is becoming difficult with menopausal symptoms, then of course non-hormonal treatments might be SSRIs, which are often termed as antidepressants. One of them is venlafaxine, which is the most popular. You have gabapentin, which is basically used as an anticonvulsant or a painkiller. And you have clonidine, which is an anti-blood pressure medication. Now, all these three groups of drugs act on the same part of the brain that triggers the hot flushes and the sweats. And often venlafaxine also is, of course, a mood elevator. And so it's mainly about flushes, sweats, and mood that these medications are targeted at. The problem is, of course, they have their own side effect. So some of them may cause drowsiness, dry mouth, or constipation, but they are mild. Generally, the symptoms only last for 2 to 3 months and then they disappear, but they can be persistent. So if someone can't take hormones or just does not wish to take hormones and manage non-hormonally, then you do have these useful medicines, which may be the best for symptom management in that situation. I see a lot of women with cancers in the past. Some of them are gynecological cancer or breast cancer patients. And of course, they do not like to take hormones because they are at a higher risk of problems with hormones. For them, venlafaxine or clonidine is very useful because it takes away the symptoms and of course doesn't have any risks, which we often attribute to hormones. Now, coming to the main bit, hormone replacement therapy. There's so much out there in the media right now, conflicting reports, lots of confusing guidelines. And of course, traditionally, it's been a topic of controversy. So what is HRT? What is hormone replacement? Should every woman have it? Or is it something that only few women need? So hormone replacement simply, of course, is replacing estrogen, progesterone, and for some women, testosterone in addition. All that debate began around the turn of the century. So hormone replacement therapy has been with us for decades. In almost 50s, 60s, 70s in the last century, it was very popular. A lot of women used HRT. Then around the turn of century, around 2002, 2003, there were two big studies, results which were published. One of them was called as the WHI study from the US, and it was a randomized controlled trial that was comparing giving HRT versus placebo, nothing, and to see how effective and safe the hormones were in the long term. And the other one was a retrospective sort of study looking at following women through questionnaires, and which was called as a Million Women study that was done in the UK. And both were big studies, and they came up with some stark results. The studies suggested that HRT increases risk of breast cancer, risk of stroke, risk of heart disease. And there was a lot of negative publicity and press at the time. So much so that as a result of that, a lot of doctors and patients stopped using or prescribing HRT. So you can see what happened with the prescribing around 2000 to 2003. Lots of HRT prescriptions until then, and there was a big crash. A lot of women who were established on HRT were left struggling because everyone was scared to prescribe HRT. And you can see the effect of that as the blue line goes down, which is the number of prescriptions of HRT. The yellow line is the antidepressant use. And you can see what happens around midlife after those studies. A lot of women with significant symptoms and mood issues could not have access to hormones and ended up having antidepressants. But of course, that has changed now. So we've gone a full circle and we've kind of said, we've looked at those results of the initial studies, the WHI, the Million Women study. We've also had 20 more years of better studies, more randomized trials, more gold standard evidence. And if we put all that together today, we find that HRT is not such a danger to women as it was often portrayed in the past. In fact, for most women who have no background medical problems, the benefits will outweigh the risk. And so NICE guidelines were updated in 2015 and then subsequently. And of course, they have kind of come up with the conclusion that more women should be offered HRT because for many, the benefits will outweigh the risk. So let's look at the three hormones. What do they do and why there is so much talk about them? Let's look at the estrogen first. So estrogen is the key hormone. It gets rid of the symptoms. It improves the flushes, sweats, the sleep, the joint aches, the brain fogging, improves energy levels. So if you're having severe, significant symptoms which are affecting you day to day, estrogen will take them away. The benefits of estrogen, of course, are more than that. It is very good for bones. It protects bones and prevents loss of bone density. It protects the heart, prevents heart attacks in later life. It improves metabolism, so less risk of diabetes. And it improves the brain fogging and the cognitive symptoms. Now, that's not same as saying it prevents dementia. We don't have evidence yet in human trials to say HRT or estrogen will prevent dementia. We can't go that far right now. But there's some evidence that maybe if you start estrogen in perimenopause, there may be some protection later on in life. We need confirmation of that. Now, there are some minor side effects that you often see when you start HRT for menopausal symptoms, like you may have some headaches, some breast pain, some nausea, but these usually should disappear after 2 to 3 months of time. What about progesterone, the second hormone that's added along with estrogen? This hormone is really required to protect the lining of the womb. So a woman cannot use estrogen alone if she has a uterus, a womb in place. That's because estrogen on its own can cause womb cancer if it's not balanced by the progesterone on the womb lining. But if you take the progesterone, you can avoid having that action of estrogen on its own. So it's always added to progesterone unless the woman has had a hysterectomy and the womb has been removed. Progesterone can have some annoying side effects. So for some women, it may cause bloating, mood changes, premenstrual symptoms. And of course, that's an entity on its own, how we often change the different types of progesterone to make it better. Not going to go into details today. The progesterone is the hormone that's linked to the risk of breast cancer in HRT. So again, the myth is it's estrogen that causes breast cancer. No, estrogen doesn't cause breast cancer. There's no evidence of that. In fact, estrogen only may reduce risk of breast cancer. If you look at the studies, the breast cancer risk in HRT comes from the progestogen or the progesterone part of the hormones. So women who have a womb will take both estrogen and progesterone. Women who don't have a womb, have had a hysterectomy, will only require estrogen. The good news about progesterone sensitivity is women who have side effects from progesterone can often get rid of them or minimize them by taking the progesterone less often or using a particular form called utrogestan or a Mirena coil. Finally, testosterone is the neglected hormone because it's not talked about usually, and it's only the last 5 or 10 years that we are recognizing that some women may need testosterone. The main and the only indication that's usually recommended right now is low libido sexual problems in women who are already on HRT but are still finding these problems persist. And so we use it for that indication. Some women notice increased energy, better mood on testosterone. It also helps muscles and bone. But again, these are some things to research in future. Which are the women which benefit from these effects? And how can we optimize testosterone for that use? We don't know much about that right now. So it's mainly the low libido. That's where we use testosterone. There are various ways of taking HRT, whether it's tablets, patches, gels, implants, lozenges, creams, pessaries, vaginal creams, pessaries. And the safest ones at the moment are considered to be transdermal. So if you take hormones in the form of patches or gels, which you put on the skin, or spray, or implant, or a coil in the uterus, those tend to avoid the oral route. So if you avoid the oral tablets, then you often avoid them going through your liver, and so they have a less risk of blood clotting. The rest of it is the same. Vaginal estrogens, many women find vaginal estrogens very useful for vaginal dryness, for painful sex, for bladder infection, urinary tract infections, which become common with lack of estrogen. They can be safely used without any progesterone required. Just vaginal creams or tablets or ink can be used very effectively for as long as required. Even with some women with history of breast cancer can use this. Again, details I'll come to in questions if you need any more details. Women who've already been menopausal for more than a year don't need to have bleeds on HRT. Women who've just into perimenopause or early menopause, then perhaps best to have a bleed, a cyclical form of HRT. And finally, the term body identical or bioidentical HRT, and this is all over media. And a lot of women come saying, I want bioidentical HRT or body identical HRT, give it to me now. Which one is safe and which one is good? Actually, body identical is the one that we recommend. It simply means you combine a plant-based natural estrogen, estradiol, with a plant-based natural progesterone, and both these usually comes from soya or yam plants. They are well studied, well regulated, and they can be given on the NHS or in the private sector, very widely available. They have a very good safety profile, and that's why we like them. Bioidentical is slightly different. It comes from plants, but these are made by individual clinics. So every clinic can mix certain estrogen, progesterone-like hormones, and then come up with their own preparation, which is usually effective. But what we don't know is, because there haven't been so many studies from that particular clinic or particular preparation, we don't know what the long-term safety is. They're not regulated like the general regulated HRT. So we say bioidentical, not recommended right now because we don't have experience with them. The body identical, we certainly know 5, 10, 15 years of safety data. So those are the ones that we recommend. Final 2 or 3 slides and then I'll stop. So the 2 big risks that we talk about. So you might ask me, you've talked so many good things about HRT, but what is the problem? Why should we not have it? And am I putting myself at risk? No medicine comes without benefits and risk. And so it's individual for you to decide, is my symptom getting me down? And am I to benefit for bones and heart from HRT? And put that against the risk that you have to make a decision whether this is for you or not. And as health physicians or healthcare practitioner, my role is to give you the facts for you to make a decision. So there are mainly 2 risks of HRT that we talk about: the risk of blood clotting that can cause stroke and the risk of breast cancer. Now, the risk of blood clotting really applies to oral forms of HRT. So if you take oral combined estrogen progesterone, it slightly increases your risk. Overall risk is very tiny. There are lots of women who can safely take oral HRT, and some who have a risk factor, it's best to do patches or gel, because if you take HRT as patch, gel, or spray, it does not increase your risk of blood clotting. So it's very, very safe. What's the risk of breast cancer? If you look at the risk of breast cancer in the population that takes HRT, then let's look at it in perspective. So in the background, out of 1,000 women between the age of 50 to 60, about 23 women will be diagnosed with the breast cancer diagnosis in that age group. If you then give them HRT, these 1,000 women, you find that 4 extra women will develop breast cancer on combined HRT. So I'm talking about 1,000 women who are using HRT for 5 years, and usually 4 extra women out of those 1,000 women will get breast cancer diagnosis. So that's a very, very, very small risk. And if we compare it in terms of different forms of risk factors, let me take you through one by one. So if you look at estrogen-only HRT, so if a woman has had a hysterectomy and is only taking estrogen for menopause, she will have actually 4 less in 1,000 risk of having breast cancer. So you can see the background risk is 23. That's just the general risk for every woman. If you take estrogen-only HRT, there's less 4 in 1,000 risk of having breast cancer. So estrogen is not the culprit for breast cancer. And that is the others. For example, the combined hormones 4 extra, estrogen only 4 less. If you look at the pill, which many, many women use early in their life, it's exactly the same risk as HRT. But nobody talks about the pill and breast cancer as much as the HRT and breast cancer. But the risk is almost same. You look at the alcohol, if you have 2 or more units of alcohol daily, 5 extra women will have risk of breast cancer. Smoking, 3 extra women. Overweight, obesity, many of us are now getting into the overweight or obese BMI, and look at the jump in the number of breast cancer. It's 24 extra women. It's massive as compared to HRT. Yet there is not much talk about this bit, but a lot of talk about HRT. So I'm not saying or defending HRTs for everyone. HRTs for those who have severe symptoms, but just to put into perspective is when you look at the risk, you always have to look at the risk in the perspective of other risk factors or medical backgrounds that you have. Exercise always helps. Women who exercise will always have less risk of breast cancer. So that's something really important with diet and lifestyle. So how long do you take HRT? There's no upper age limit. Most women will take HRT between 50 to 60 or 65 for 10 to 15 years. And then after that, they will gradually come down the dose and stop because most of the benefits are done and the risks become less and the body gets used to less and less hormone. And often most women after 10 or 15 years will not have any symptoms. Occasionally, if someone continues to have symptoms, they may continue into their 70s and 80s. As long as benefits outweigh risk, it's an individual choice whether to continue HRT or come off it. So that's my last slide. Menopause should be viewed as an opportunity to make changes in lifestyle. This is the time to act because if you're in your 40s and 50s and you've had menopausal onset of perimenopause, this is the time to look at diet, exercise, screening for bone health, making sure your work-life balance is okay, stress relief, mindfulness, and if you're symptomatic, of course, considering HRT as one of the options alongside all the rest lifestyle and other interventions that you do. So that's a rapid fire course on menopause. I'm sorry, I'm very fast because there's so much to cover and I want to take as many questions. So I'll stop sharing my slides now and then hopefully we get plenty of questions. Thank you.
Thanks a lot. Thanks a lot, Dr. Talaulikar. It is a lot of information and a lot of very useful information, especially HRT, because this is something we have not covered in Miyara before.
Honest, there is no clear answer here. And that just goes to show how little we understand about hormones. Although we claim that we've cracked it with HRT, with menopause, actually, we probably just scratched the surface. So we know certain changes happen with the lack of estrogen and the lack of testosterone at perimenopause, menopause. So it certainly slows down your insulin. It certainly changes how you respond to stress and cortisol. We also know that there is change in fat distribution in the body. So you're kind of running on a very slow metabolism that has suddenly been sort of made 50% or 25% of how active the body was. And so a lot of women exactly in your situation, despite having very good HRT, good estrogen, good testosterone, doing their workouts, eating healthy, doing different diets, do not achieve that level of either BMI or fitness that they want. There's no easy answer to that. So if you asked me, is there a solution or are we getting close? I have to disappoint you, no. The same advice follows is that continue doing the exercise, continue doing the stress relaxation, whatever you follow, continue sticking to the diet that's healthy, but also make sure that if you are having symptoms, HRT is really going to help. Not directly by changing your metabolism easily, but it's going to make you feel energetic enough to follow things. For example, the diet, the exercise, it will keep you more energetic, more active in terms of concentration and brain. So you can then continue to do everything right with diet and exercise. Now, there are research groups looking at, can we find out how the lack of estrogen causes this big metabolic shift? If we get an answer to that, whether it's a hormone, whether it's a marker or chemical messenger in the body that does that, that will be when we will have an answer to exactly what you're going through. But until such a time, watch the space, do all the right things, and I'll come back to you if we have the final answer.
Is HRT a magic pill, or is lifestyle intervention required even if you are on HRT? So
Well,
that
HRT certainly isn't a magic pill, Sanjana. You're right. It's not a magic pill. It doesn't mean that if you take HRT, you're going to undo all the effects of menopause. It will help with symptoms. It will help improve your quality of life. If you have risk factors for bone loss or heart disease in your family, it's going to be worth considering it because it will give you protection. But the crucial bit is really to continue doing the healthy lifestyle bits for all of us. That is what will see us through till the end.
How do you know if you're on the right dosage of estrogen? How does adding testosterone affect aggression and mood?
Okay. So in terms of the right dosage of estrogen, it's usually based on your symptoms. So the first thing is to always say, why did I take HRT? Why did I think of having estrogen? Yes, I was having hot flushes, night sweats, or some other typical set of symptoms. Is your HRT addressing that? So if your symptoms are not being addressed, of course, either you're not getting enough or that particular form of HRT is not right for you. So it's the symptoms that we work on when we decide to go up the dose. We always start with the lowest because you should be on the lowest dose. Don't take anything that's not required. And then from that lowest dose, based on your symptoms, based on your side effect, we keep going up and up within the safe range, licensed medication, until we hit a level where you feel, okay, 90% of my symptoms are gone. This is much better day to day, and I don't have any significant symptom. Okay. Now, occasionally we may do blood test. If we think you're not absorbing at all, there's a problem with skin absorption or oral tablet absorption, we may do a quick estrogen level, and we just make sure you're having levels more than 200 or 250. That is just to check absorption, but really the clinical response is the key. For testosterone, it is mainly for low libido, sexual dysfunction, and you find that despite having estrogen, progesterone, HRT, you're not getting that bit improved, then testosterone may have a role. Of course, if you should be sticking to the lowest small doses that we recommend, and that may indirectly also improve your mood. If you increase the dosage too much on your own or your physician increases it too much, then sometimes some women do feel aggression is a side effect of that. It's very uncommon, but of course, that's why you want to stick to the tiny, tiny dose, which is not meant to do any of those changes to you.
Okay. And the other question in the same line is, can I take testosterone even if I'm not taking any HRT? So I think the question is estrogen or progesterone. Can you still take testosterone?
The short answer is yes. Generally, testosterone works best when you already have estrogen in your system. So one would always recommend to do estrogen, progesterone first and then add the testosterone. That's the clinical experience we have. We always find it works better that way. But occasionally, some women may want to avoid specifically estrogen, progesterone. Then testosterone on its own can be used, but you need a discussion with your doctor or your healthcare professional of the pros and cons of that, but can be used.
Estrogen only HRT be helpful for elderly women 70 and above who have not used HRT previously?
Well, if you're 70 plus above, it's not common to use HRT because one, the symptoms may not be typically lack of hormones, although they could be, nobody's exception. But generally not. Secondly, if you're worried about bones or heart or long-term health, there are non-hormonal interventions which can be more effective and safer at that age. So if you're starting somebody on HRT after 70, it's usually for typical severe menopausal symptoms and not usually for long-term health at that point. If you do start, then of course there's a discussion between the doctor and the patient about pros and cons. If you have the uterus, if the woman has the uterus in place, you can't give estrogen only HRT. If the woman has had a hysterectomy, yes, you can offer estrogen only HRT in that case, but do have a balanced discussion about risk benefit. We do have patients who have occasionally started HRT late in life, in their 60s or early 70s, but it's maybe 1 in 1,000, so it's not very common.
There's also a question about hysterectomy. Someone with retained ovaries, can natural progesterone fluctuations during perimenopause increase the risk of breast cancer if they don't have the ovaries, but a hysterectomy?
They have ovaries, sorry.
I mean,
So
they
if-
have ovaries and
So if you've had a hysterectomy and your ovaries are conserved, you will continue having your natural estrogen progesterone being produced in the ovaries for a few years after hysterectomy. It is thought that hysterectomy may hasten the onset of menopause. So once the uterus is removed, there is some issue with the blood supply in the pelvis. And for some women, menopause happens earlier in a few years' time. Your risk will depend on your background, your genes, your family history, your lifestyle, your alcohol or smoking, your BMI. So per se, I wouldn't attribute that after hysterectomy, your risk per se will change. No, it will be more or less similar. The only thing that may change is you might have your menopause slightly earlier than you were destined to. And so that can then have a bearing on your heart, your brain, your bone health in future.
Another question is, would appreciate your perspective on late menopause. Are there risks involved? At 54, what does estrogen do to your body?
Okay, so late menopause is often considered beyond 55. So what we consider usually is a range between 45 to 55 to be quite a wide range of when women can attain menopause. So a lot of women have menopause around 53, 54, 55. Clinically, not much of a difference. Yes, you've been exposed to estrogen throughout your life for longer than many other women. But in terms of decision making about symptoms, HRT, or what should be taken, it doesn't differ. If you've had a late menopause, you probably will have good bones because you've had more estrogen exposure in your life. Your bone health will be better. Your heart health should be better, theoretically. Of course, depends on your lifestyle and other medical problems, but I wouldn't necessarily make a big difference. If you're symptomatic, it's still worth considering HRT or other interventions.
So estrogen exposure during life does help you with, being healthier.
Yeah, so
Okay.
one would expect for an average female to have estrogen between the ages of 13, 14 until, say, perimenopause, menopause happens around 45, 50. And so you're looking at least 35 years of estrogen. Every month there will be ovulation and estrogen being produced. And so that sort of is considered as an average estrogen exposure. Any more can help with certain things, bone, heart. Extra estrogen may sometimes be considered as detrimental for breast pathologies, although we don't have solid evidence for that. And any less, if you go through premature menopause, you have late puberty, less estrogen can then mean your bones may be more vulnerable, you may be more vulnerable for heart disease. But there are so many other life factors which kind of have an influence. It's difficult to just go by one factor in life.
Absolutely. There's also another question because I think this is important because in India, a lot of doctors don't generally prescribe HRT. So the question is really, do we need to consult an endocrinologist or an OB/GYN in order to get HRT in India? I don't know whether you have a perspective on that.
It's a difficult one because, again, we do sometimes workshops for overseas doctors and the same question actually crops up. I think it depends on individual person what they specialize in. So for example, a lot of endocrinologists who do women's health endocrinology will do menopause and HRT. At the same time, a lot of gynecologists are now getting more aware about menopause and picking up menopause and HRT. Surprisingly, a lot of general practitioners or women's health doctors who may not necessarily be gynecologists are also picking up this and prescribing HRT or looking after menopause related health issue. So I think it's a bit of hunting process. I've had lots of patients who often ask, do you know somebody who I can go to? And I often have to say no, because I have no idea. But I think if you search using either internet or any other portals where you can search for doctors who specialize, you will certainly find somebody who specializes in menopause and HRT. And I know there are not many, but it will improve because more and more people are getting aware and training themselves. So in the next few years, you will see more people offering help. A lot of women find that they have onset of ADHD symptoms or worsening of ADHD when they get to perimenopause, menopause. Because in women's health, a lot of conditions are interlinked, whether it's PMS, PMDD, ADHD, allergies, a lot of symptoms or conditions where we thought there may not be hormone basis. It's turning out that the hormones are interlinked with many of these conditions. And so it's not surprising that some women receive their diagnosis of ADHD during perimenopause, and some of the hormone changes can exacerbate symptoms. Always talk to your health professional, whether it's your doctor or your gynecologist, who may then signpost you to the relevant specialist who specialize in this. There are some of us who specialize in this area, who kind of look at the psychological aspects of condition alongside physical aspects of ADHD and menopause. And of course, you need to tailor your treatment to both. But again, it's a part of a specific topic I think we'll cover in future.
And also a lot of women have told us about digestive issues during perimenopause. Is that a common feature that women see that come to you?
So again, digestion issues are common. One, during menopause, for example, the lack of hormones can impact some women about what they eat as well as how they digest. That's the slowing down of metabolism I was talking about. But also remember, HRT itself can affect digestion and gut. The progesterone is a gut slowing medication. So some women find that things like reflux disease, acidity, or constipation or irritable bowel syndrome can worsen on HRT. And you might have to adjust the type and the level and the dose of progesterone to kind of get things in balance or get things right. So it's very variable. Everyone is a little bit different, but yes, there is some link to gut issues during menopause.
And there was also a question about swelling that has cycles and doesn't go away and only started in perimenopause, regardless of what this person eats. The person was put on progesterone for 6 months and it disappeared, and she felt amazing. After which she's eating well and exercising. What else can she do?
It's a little bit difficult to go by the question itself about swelling, because there can be so many causes for distension or swelling in the abdomen. I think in general to say, as part of perimenopause or menopause, you can have a few body changes. For example, more chance of bowel distension, more chance of fat distribution around the belly or the truncal area, slowing down of your metabolism that can contribute to all this. But also because your hormones are fluctuating, if you're sensitive to progesterone, you can have swelling or bloating or tummy issues because of the progesterone. And maybe when you took the continuous progesterone treatment, it might have stopped those fluctuations happening. I can only second guess because I can only go by the little information I have. But again, if you're worried about this coming back or happening again, see your doctor, and they'll be able to advise you based on exactly how and when the symptoms started. All other advice would be general health lifestyle advice. So make sure any foods that cause you bloating, avoid them. Healthy lifestyle, no much alcohol, exercise regularly, some gut healthy foods which you can find on the internet, they may be helpful as well. And then finally, HRT. If hormones did improve symptoms in the past, then maybe consider HRT again, but make sure you're on the right ones by talking to your doctor.
Are there alternatives to help vaginal atrophy than using Vagirex?
Okay, so yes, there are alternatives, of course. If it's the vaginal atrophy, dryness, or the bladder issues, then of course you have the lubricants, the moisturizers, which are non-hormonal preparations. If they don't help, you have the vaginal estrogen, either in the form of the cream, the pessaries, or the ring. If estrogen doesn't work, there are two new preparations, something called oral tablet of ospamifene, which is an estrogen receptor modulator, or you have vaginal DHEA, which is another hormone which can be given locally vaginally. For women who don't do well on estrogen, those two would be the new medications. Some women also try to do heat therapy with special machines or probes which use laser or heat in the vaginal area. I don't recommend the last bit, the vaginal laser, because there's not much study about long-term effectiveness and safety. So I think the medications, the estrogen, DHEA, or the lubricants, moisturizers would be the best ones to try. Sometimes you have to be regular and persistent and only see benefits 6 months or 1 year down the line. So don't give up easily.
So vaginal atrophy, do all women have to go through it, or is it?
It depends. Everyone is different, as I said. Some women will find that the vaginal dryness is unbearable. They pick up infections, have pain during intercourse. Others surprisingly find that those are not the main issue. It's the systemic symptom. So about I would say 60 to 70% of women have vaginal symptoms, and out of them, about half of them will have quite severe symptoms. So if you're in doubt and if you feel that things are not comfortable, then vaginal estrogen or any other lubricants is very safe and effective treatment. So don't stay away from it. Don't suffer in silence.